Ma'am, you are muted, I believe.
This always happens. I start and it is muted. Thank you so much. And good afternoon, everybody. And yet we are back again with another session on GI symptoms. And last class we covered on nausea, vomiting, constipation. And many of you had doubts and had asked questions regarding how to manage malignant bowel obstruction. And that's exactly what we are going to be dealing with today. So let me just try share my slides. Is it moving or is it the same issue as last class?
No, ma'am, it's perfect.
It's fine? Okay, right. Yeah, so as we talk about bowel obstruction, we have seen bowel obstruction as in constipation. And sometimes when we see palliative patients, especially cancer patients, we understand that the bowel obstruction is something more serious. That is, there is a malignant background to it, which is the reason for bowel obstruction. So this is a tough time for the patient, and it's quite an ordeal to relieve the patient at this juncture. So let us see what we can do for a palliative patient with bowel obstruction. So what I intend to take you through is the classification of bowel obstruction and the symptoms, what your patients will be presenting to you with, and how will you come to a diagnosis of bowel obstruction, and how will you manage your patients, and what is the treatment, how is it different in palliative care from what is usually being practiced, especially towards end of life. How is it different? How is it different from what you treat bowel obstruction in the curative phase of the disease trajectory? Right. So would you like to share as in what is the symptoms your patients could present to you with? What would be the symptoms that the patients or complaints that the patients would come and tell you with bowel obstruction? Pain, distension, vomiting. Dr. Vikram says so. Yeah.
Constipation.
Constipation, yes, thank
vomiting,
you.
Nausea or vomiting. Yeah,
nausea, vomiting, yes. There is so much of distension which is causing the nausea, vomiting, yes.
Sometimes due to vagal stimulation, hiccups also.
Yeah, right. There is also diaphragmatic irritation in the process of so much of distension and all that. And again, that itself also could cause hiccups.
When melena?
Melena, yes, it's probably if there is a tumor invading in and causing bleeding, definitely. Yes, bilious vomiting, yes. Anything else? What would the patient be telling you? Yes, you did give me pain, distension, vomiting. It's coming with a bowel obstruction. No flatus and stool, exactly. The patient, Dr. Bikram, Dr. Shilpa, Dr. Janaki. Yes, Dr. Janaki has put in her name. Yes, would you like to add in something? So these patients are going to present to you with distension, constipation, nausea, vomiting. You've got the list there. All of you have come up with what patients could present to you with. So moving down, we come to this case report. Yes, This is the story of Sarah, and we will be listening more of what Sarah went through as we move on further. Okay, so Sarah is a widower, and she is 62 years old and was diagnosed with stage 4 of CA stomach with metastasis to the peritoneum and anterior abdominal wall. And she underwent surgery. She had a palliative distal gastrectomy done and also chemotherapy. But unfortunately, what happened was after the second cycle of her chemotherapy, a CT scan taken showed that she was having progression of disease into the peritoneum and abdominal wall. So then this is just a gist of the story of Sarah, and there are so many Sarahs out there, so many people who are presenting with distressful symptoms of bowel obstruction. So as we move on, I would like to have suggestions as to do you have an idea like what are the different types of bowel obstruction that the patient could have? Like what is like the basic classification?
Small intestine and large intestine.
Yeah, if it, based on the site, definitely small intestine, large intestine. Yes. If not for the site, maybe the duration.
Acute and chronic.
Acute and chronic. Yeah. And anything else? Like you see a mass right there. Okay, partial, total. Dr. Vineetha says partial, total. Dr. Shweta says a number of sites involved. Yes, Dr. Bikram also says partial and total, a complete. Yeah. And what about if, is it that every obstruction has to have something sitting there and obstructing the lumen? Does every bowel obstruction need to have something sitting there and obstructing the lumen? Not always, yes. So sometimes there is nothing there and still there is a bowel obstruction. And that is because it is a functional or a adynamic bowel. So let's get to the classification. Yes, there could be adhesions also. Yes, rightly said. Right, and then Dr. Vineetha also adds in mechanical and functional. Yes, thank you. And a lot of you have answered ileus. Yes, that is the two different type of obstructions that is based on the site. You have the small intestine and the large intestine, right? So coming to the classification of intestinal obstruction is mainly non-chemical and as non-mechanical and mechanical. Non-mechanical is basically when there is a functional obstruction or the absence of peristaltic contractions, and the pain in non-mechanical obstructions is lesser when compared to that of mechanical obstruction. And if you examine a patient, there will be absent bowel sounds. Whereas if you look at mechanical obstruction, again, you can classify it based on the duration of onset. It could be acute, chronic, acute on chronic, or based on the site, you have the small bowel, large bowel. Based on the nature, you have simple, closed loop, strangulated. Now, strangulated is an emergency. Based on the etiology, you have intrinsic, extrinsic. It's in the lumen, which is obstructing. Extrinsic, it's over the lumen, putting on the pressure, and it's extrinsic. And it could be intraluminal, where you have the tumor invading in and causing the obstruction. Now, other than this, based on the nature, it could be simple, closed loop, or strangulated, like you were saying. That is simple, like earlier one of you was saying, it could be multiple sites, it could be a single site. So if it's simple, there's only one site, there's only one obstructing point, and there is no vascular compromise over there. Whereas when it is a closed loop, there are 2 points of obstruction, and the loop which is in between is grossly dilated. And here, because of the gross dilation, there is always a risk of perforation. And when it comes to strangulated, here the vascular supply is compromised. And the pain is very severe. It's very sharp. It is associated. The patient also presents with vomiting, melena, and there is peritonism, features of peritonism, and the patient could present with fever and increased WBC counts, and these are also compiled along with the other signs of mesenteric ischemia. Right. So we were looking into what are the causes of obstruction. So there were so many, like some of you were saying additions, some of you, well, we didn't get too much into what could be the other reasons. So we were talking about dynamic and adynamic causes. Now, dynamic causes is because there is something sitting there. So that could be a foreign body. It could be something that has gone and impacted and blocked the lumen, or it could be stones, such as gallstones. It could be a stricture. It could be RT induced, or it could be surgery induced, or it could be a malignancy. Now, extramural would be, again, additions, again, because of RT, or that the patient has had radical surgery, abdominal surgery, which has led to the extramural additions. Hernia also could present with, and also probably lead on to strangulation. Volvulus, again, yes. Intussusception also. All these could also lead to strangulation. Now, adynamic causes, you have paralytic ileus, mesenteric vascular occlusion, and pseudo-obstruction. So these are many things that you already know. All these we have learned in our academic years. So how do we see the symptoms of these patients who present to us? Because that is our concern. In palliative care, not always we are able to completely cure the situation. Okay, you have a patient who presents to you with pain, distension, constipation, and vomiting because of obstruction there. But you are not able to reverse it because it's because of cancer, probably. And what you can do as a palliative personnel would be to relieve the patient of the symptoms. So you need to know the different component of the symptoms so that you can plan your management for each of these. So that is what we are looking into, right? So someone who could present to you with a partial or complete obstruction could have severe colicky pains, and colicky pain, the patient tells you, I have this severe pain coming in, and it goes off, but then again it comes very heavily. So there is a fluctuation there, which tells you it is colicky. And again, partial and complete obstructions, there is decreased movement of intestinal contents. Now, this will contribute to the distension. There is increased gut epithelial surface area also, and there is increased bowel secretions also. So much of distension, so much of secretions that is happening, and all this could lead to nausea and vomiting. And now, because of all this, there's again damage of the epithelium because of the inflammatory responses that is happening, and this will lead to the pain. So we see three things which is marked in red here. That is, okay, that is one is continuous pain. Sorry, the other one is the bowel distension. Sorry, that's in yellow. So we have the pain, we have the distension, we have the nausea and vomiting. So along with the constipation, we have these three things that we have to be tackling. So how do you think you are at a home setting, and these are the symptoms that your patient is telling you. The patient has cancer, a history of cancer, and tells you that I'm feeling very nauseous and I'm vomiting also. I have not passed stools for about 7 days right now. And and you think it is a bowel obstruction. So is there, what is going to tell you where is the bowel obstruction? Is it a small bowel obstruction? Is it a large bowel obstruction? How will you diagnose it? Yes.
Small bowel, the vomiting will be the predominant feature, whereas large bowel, it will be the passage, lack of passage of flatus or stool, that will be the predominant feature.
Yeah. Yes, I would agree to you. Definitely, it is a small bowel obstruction which presents with lot of vomiting, high volume vomiting, and obstruction. I mean, bowel obstruction per se would that is complete bowel obstruction per se would present with no flatus, no stool. And again, well, Dr. Bikram says X-ray, USG. Okay.
The stool examination will help.
Stool examination. Would you like to add in?
Yeah, if there is only blood in the stool, it shows it's a large bowel obstruction. Maybe necrosis.
Well, we are at a situation that there is no stools, and blood in the stools could also be because there is a malignancy per se. And
no, usually in the acute abdominal obstruction, I think acute abdominal obstruction, if it is a large bowel obstruction, this is one of the important tests. I hope so. Stool examination.
Well, I would be of the opinion that you would get a blood in stool or occult blood in stool, whichever be it, in a malignant bowel situation, anyways, or maybe, okay. So I don't know how much we can depend on that. And if this is a patient who is on chemotherapy, and this is a time when there is the neutropenic phase, the pancytopenia, where all the parameters are low, thrombocytopenia is also there, and that is probably also contributing to.
Okay. No, when we are discussing only about the CA stomach, no problem. It's a CA case, then no problem.
Yeah,
I was in general, like acute usually we go for the stool examination.
Okay, so I was thinking that we could discuss on how at a bedside we can actually have a vague idea. Okay, this is an obstruction, this is a small bowel obstruction that we are looking at, or this is a large bowel obstruction we are looking at. So I do get answers here like X-ray, USG. So what is it that in an X-ray that you are thinking about?
Air
Yes.
level, air level obstruction.
Yes, we are seeing multiple air fluid levels. Yes. And we are also seeing dilated bowel loops. Yes, thank you. And anything else? Okay, these are the most classical findings. Okay, auscultation findings before imaging. Definitely, we have to do examination. We have to inspect the abdomen, and on inspection, what is it that we would be looking at? Yes, for abdominal examination, what would be the signs that tell you, yes, we are looking at obstruction? Is there something that would be telling you, you're just looking at the abdomen, just looking? Yes, you see that the abdomen is distended. What else are you looking? There's no any obvious mass. Okay, what if there is a mass? All right. Yes, Dr. Johnsy says that you could be seeing a visible peristalsis. Yes, Dr. Janaki, would you like to add it? You just raised your hand.
Yeah, obstipation.
Obstipation, yes, when there is absolutely no passage of stools, or yes. Okay, but you are looking, you are examining. I mean, sorry, you are looking at the abdomen. So you are looking for distension, you are looking for visible peristalsis. You're looking if there is a mass, right? So these things are going to tell you. Then again, you auscultate, you see that there are no bowel sounds. Again, this is towards bowel obstruction. And again, with your history of how is the vomiting? How is it that you vomit more than you take in? That question might just lead to the answer. Your patient might tell you, I don't know how much of water, from where so much of water is coming, but I'm just going on vomiting so much. So that itself is like a clue that we are looking at a small bowel vomit, because it's very classical. So that is what I wanted to discuss about. The level of obstruction determines the pattern of symptoms, and high level obstruction, it could present as vomiting, which develops early and is very large in volume. And large bowel obstruction is generally progressive, and abdominal distension is more in large bowel obstruction. So these will be your differentiating factors. And in case there is a complete obstruction, there is no flatus, there is no no stools, and there could not be spurious diarrhea. Yes, one of you also did mention spurious diarrhea as one of the complaints in the chat box. Thank you for that. And like you rightly said, in an X-ray, we are looking at multiple air fluid levels, which is very classical of bowel obstruction. So what you need is an erect abdominal X-ray. And okay, again, if you want to go for the higher end imaging modalities, they are also available. But what matters is what is available with you in your setup. And always with the help of history, especially most of your palliative care patients are at home, right? And they sometimes cannot be transported. So before you want to plan your management, you might not be able to transport the patient to the hospital. So you need to have a kind of idea about how to come to a diagnosis, even at a home setting. So now coming on to planning and management. How are we going to manage this patient? Yes, suggestions in this chat box so you can speak. What are the drugs we are going to use? What are the areas that we are going to focus? What are we trying to control?
That also depends upon the, like if you suspect lower abdominal distension or large intestinal obstruction, you should not give any oral enema or oral laxatives.
Oral laxatives.
You should try for manual evacuation or it's enema.
Yeah, I agree to that as well. Anything more? Yes, we got one suggestion that the patient should be given enema after a digital evacuation, because most probably there's going to be impacted fecal mass over there. So there is no point giving laxatives or just giving an enema. You need to clear the route before you actually give, and probably give even a high-end enema, right? Yes. So Dr. Shilpa says nil per oral. Yes, also Dr. Rajendran also supports that nil oral, NG tube insertion, IV hydration. Yes, Dr. Shilpa says Riles tube aspiration. Yes. So what exactly are we targeting for when we are talking about nil per oral and Riles tube aspiration? What are we trying to relieve? Decompression of the abdomen, yes. So that's exactly why we put in the Riles tube and ask the patient to be nil oral. Now, I would also support that if we are looking at a patient in the curative phase. Now, this would be a bit different when we are dealing with patients at the end of life care phase, right? Here, when the patient has few days more left and is in his terminal phase, I am skeptical about how much I want to push in that Riles tube down his nose, when that is going to cause him discomfort, and when he is actually telling you that He's very hungry and he's very thirsty and he wants to drink something. So generally in palliative care, what we say is that you can give sips of fluid or probably liquid, something liquid, small amounts, just as much as the patient tolerates. So generally we advise that. Decompression, definitely if there is a lot of distension and your medications are not helping, you can put in a RICE tube. And of course, ask the patient if it is comfortable for him, because we respect what the patient wants. This is autonomy that we are talking about. In palliative care, we give full respect to the patient's wishes also. So you ask him, can we put a RICE tube for you? Is that fine with you? And then you can put a RICE tube and you take it as a temporary measure. You deflate, you and check for the relief of symptoms, and then decide whether you want to keep that on. By then you have your drugs going 24/7. Yes, and we also have some suggestions about drugs like morphine and metoclopramide. So morphine is going to help you if it is severe pain, definitely. Now, metoclopramide, again, we are looking at a double-edged sword when we are talking about metoclopramide, because metoclopramide, we know, is a prokinetic, right? So when you have prokinesis and you have the peristaltic waves being stimulated against an obstructive site, this is where what leads to more of increased pain, right? So this is what leads to more or increased pain. So you need to be careful when you think about suggesting metoclopramide for a patient who has complete obstruction. But if you have a patient who has subacute obstruction, then probably metoclopramide would be your choice of antiemetic, because it's just a subacute obstruction and there is not much pain. So probably whatever prokinetic that you are giving, it will actually help to move the bowel further. Now, Dr. Deepak says that can we try octreotide? Definitely, octreotide is an anti-secretory agent. Your patient with a small bowel obstruction who is having a high volume vomitus is definitely going to benefit with octreotide. So along with the antiemetic, you can also give an anti-secretory agent like octreotide. Yes, and Dr. Vineetha also says antiemetic. Dr. Ravi says patient will be in more distress at times. He just needs to address the situation. In complete obstruction, avoiding perinom is better. Yes. Yes, exactly. Yes, I know a lot of you are also agreeing to the fact that metoclopramide is the best suggestion only if it is a partial obstruction. Now, Dr. Shweta asks, what about hyoscine? Yes, hyoscine butyl bromide is also one of my favorite drugs that I usually prescribe for patients who are having bowel obstruction, because they act in two ways. It helps to bring down the colicky pain, one, and two, it is also an anti-secretory agent and it helps to bring down the nausea. I mean, the vomiting volume. So these two ways I like adding butyl bromide, hyoscine butyl bromide or Buscopan for my patients who present with bowel obstruction. So coming on to other aspects of planning and management, like you all said, a patient who presents with symptoms of bowel obstruction, you have to do a complete clinical assessment. It is not just imaging. Yes, all of you have agreed to that. You have to clinically examine the patient. And along with that, you could couple it with radiological assessment, especially if you have the facility available in your hospital. And the patient is in a curative phase. Again, I would like to underline that because you have to justify using or advising the patient to take expensive investigations, especially if the patient is in the end of his life. So plan it timely. And again, when it comes to what do you have to do regarding a malignant bowel obstruction, well, we did talk about the drug therapy. We did talk about the drug therapies, but we did miss out one. Other than the medical management, what other aspect? Yes, Dr. Shilpa also added in dexamethasone, and Dr. Sharvanan also talks about stents. Thank you so much for adding in those points. And yes, dexamethasone is like the wonder drug for pretty much most of the symptoms that we manage in palliative care. And how does dexamethasone help in managing bowel obstruction? Yes, would you just like to add on just that one point more?
By reducing edema.
Yeah, it helps to reduce the peritumoral edema. So you have the lumen there and you have the tumor mass over there, and it is obstructing the lumen. But you might not be able to completely decrease the tumor mass, but the tumor is got a peritumor, it's got an edema around it. So by giving dexamethasone, you can reduce the edema around it, and you are going to get that little space in the lumen. So that is how dexamethasone is going to help you. And then talking about stents, yes, definitely stents is also another option that we have. And other than stents, I think you all missed the whole part of surgery. We didn't talk about surgery, isn't it? Yes, as a curative aspect, we go for surgeries also for patients who present with malignant bowel obstruction. And they are given colostomies, sometimes a permanent colostomy, sometimes a temporary colostomy, and the colostomy reanastomosis is done after the entire treatment. So coming to other decisions, so who for surgery, who for medical management? This is what malignant bowel decision making is all about. So what you need to think about, you need to have a checklist which helps you to decide which way your patient has to go. So these are some things that you need to look at. One, the age of the patient. Now, is age exactly a criteria? Is it that every patient above 70 years, you don't have to actually do anything? I did put it up here in the list, but I would definitely say that I'm sure, not many of you agree to that. Nor do I completely agree to that, even though it is given in this table here, because age is just a number sometimes. So it's mostly the performance status of the individual that we look at. How was he before? So you can take any two performance status. You can go for the ECOG criteria. You can go for the Karnofsky's performance status criteria. So also you look at the stage of the cancer. Is it the beginning stage? Is it the stage 4 when it is actually metastasized to the different vital other organs? So actually whether your surgery is going to have any change, is going to bring about any change for your patient. Then again, you have the future anti-cancer treatment options. You have to discuss about the future anti-cancer treatment options that is available for your patient with the oncologist, because it is not just curative chemotherapy that is available, but also palliative chemotherapy which is available. Right? So what does palliative chemotherapy do? Palliative chemotherapy helps to bring down the symptoms. So the chemotherapy is given with the intent of relieving the symptoms, or probably decrease the tumor to a smaller size, right? So you discuss about the further options, what is available for the patient, something which is not that toxic, which the patient can tolerate, but yet will relieve the patient. So that should be done. And also look at the nutritional status of the patient. Some of them might be very cachexic, and also the other comorbidities that the patient is having. Also, other disease factors, such as the extent of obstruction, say it is a single obstruction or it's a multi-level obstruction. So it is actually difficult to think of a surgery when there is multi-level obstructions. It would be a very radical surgery. Then again, the site, whether it is a proximal bowel, whether it's a distal bowel, again, whether it's a functional or mechanical. So functional bowel obstructions, maybe they are adynamic bowels. It's sometimes even contributed by just electrolyte imbalances, something which is totally reversible. So again, you look at what is the etiology, whether there is ascites, whether there is carcinomatosis peritoniae. Now, these are all poor prognostic factors. So these are some factors which, if present, tells you that your patient is not a patient who is fit for surgery, and you go in for medical management. So the other technical factors, the degree of invasiveness, you can assess it by radiology, endoscopy, laparotomy or laparoscopy, right? So this is basically a flow chart that should run through your mind when you are planning a management for a patient who comes to you with features of bowel obstruction. So poor surgical prognosis would be advanced stage with cachexia, wide tumor spread, ascites, low serum albumin, severe nutritional deficiency, palpable abdominal mass, or any previous radiotherapy to the abdomen or pelvis, because these situations it is pretty sure that these patients are going to have a lot of additions. So it's not going to be just one obstructive site there. There are going to be multiple additions which are contributing to obstructions. Now, history of combination chemotherapy, because combination chemotherapy, what I meant here is that different lines of chemotherapy. First line chemotherapy, second line chemotherapy. So it tells you that the patient has progressed further despite different lines of chemotherapy, which tells you that it is anyway a poor prognosis disease. Again, multiple sites of obstruction, poor peristalsis because of carcinoma peritoniae, and poor performance status. So all these are factors which tell you that this patient has to go in only for conservative management. So treatment, yes, we did get many of these in the chat box, and I'm so happy to see that. Laxatives, like the suggestion was, if a patient is having total obstructions, better not to give orally. You do a manual evacuation, do a enema, or probably a high-end enema. Now, if it is a partial obstruction, you could also give laxatives, lubricant laxatives, stool softeners, or you can also go for stimulant laxatives, right? And corticosteroids like dexamethasone. Now, dexamethasone, generally, I prescribe a dose of 24 milligram IV once a daily dose for about 4 days for my patients who present with malignant bowel obstruction. And I check for the relief of symptoms. Now, there are some people who give probably lesser doses, but generally with severe malignant obstruction, I usually prescribe a dose of 16 milligram to 24 milligram. And always remember, when you prescribe dexamethasone, to give it as a once daily dose, because that's all that is enough. You don't have, it's got a longer duration of action. So you don't have to necessarily give it 8 hours. And again, try not to give it in the evening or at night time. It is better to avoid that time because it can interrupt with sleep. Now, coming on to antiemetics, yes, again, if it's a partial obstruction, we can go for your suggestions like metoclopramide. And again, if it is a complete obstruction, so then which antiemetic would you suggest? If it is a complete obstruction.
Hyoscine.
Hyoscine butyl bromide. Okay, it is an anti-secretory agent, so it is going to decrease the volume of the vomitus. What else?
Domperidone.
Domperidone, also like metoclopramide, it has some prokinetic action. So that is also a bit of an issue.
Even dexamethasone in this high dose should be an antiemetic, isn't it?
Yes, it also has antiemetic features. Now, we know from our slide yesterday that dexamethasone acts in the receptors in the cortex, cerebral cortex. So we need to get the other zones also, like the CTZ or the vomiting center. We want to go reach there. So we have to sometimes combine it with other agents also. So we could also try antiemetics like ondansetron, or we could also try other antiemetics like haloperidol. So these are all different medications, antiemetics that we use in such a case. Now, I have some questions here, like, yes, Dr. Bikram was saying that autonomy should be given all respect. Yes, many patients will not like a permanent stoma. Yeah, so we have to ask the patient because stoma is very distressing for patients because they always feel they are unclean. Many of them, they become a total introvert after they undergo a colostomy. They do not like to meet people because they always feel that the other person will feel that they are dirty, or because, you know, the gases are emitting from the stoma. So they feel very embarrassed because of that. And I was working for 10 years in Calicut, that is the northern part of Kerala, where we have a lot of Muslim patients coming in. And this was one of the problems that I saw in most of my patients over there. Like, because they have to do the namaz, they always felt, colostomy patients, they always felt very deeply hurt inside because they felt that they were not clean enough to even do their prayers. So definitely we have to ask the patient for his or her consent. And again, I have a question here. What do we do after 4 days of dexamethasone? Do we abruptly stop? Yeah, generally what I do is that I taper it down. I taper it down and I stop it. So I do not stop it abruptly. I taper it down and stop. Generally, if it is just given for 4 days, you can, and the patient develops a very good bowel, you could stop it immediately. But generally, I taper it down and stop it and observe the patient whether the patient is having a persistent relief of symptoms. Dr. Manber also adds in PPIs. Yes, PPIs could help if the patient is having features of gastritis, or the patient is also going to benefit with some prokinesis. Ondansetron can lead to constipation. So how is it possible in the role of obstruction? That would be a good question by Dr. Ravi. Definitely one of the side effects of ondansetron is constipation. So we also have the other option of giving haloperidol. So generally in palliative care, we do use haloperidol quite often for its antiemetic property, right?
With what dose are we using it, ma'am?
We give it a dose of 1.5 milligram IV, like say about 8 hourly or 6 hourly, or sometimes we don't have to go, don't compare. I mean, it's not like, we often have to go beyond that dose, but sometimes we do, especially when the patient is having severe intractable vomiting and all that, we have to go. Could there be a recurrence of the obstruction? If yes, the choice of drug. Yes, malignant obstruction, especially in progressive patients, is always it's a vicious cycle. Like, once there is always exacerbation. So once you deal with it, it comes down, the patient is relieved. But again, inside the disease is progressing. So there is always going to be another obstruction that is coming up. Now, again, another very interesting question. What about morphine-induced obstruction? Constipation. I was just waiting for that question from one of you. See, it is that morphine definitely has a side effect of constipation. You could start your patient with analgesics such as paracetamol, 1 gram IV, 6th hourly, or you can give your patient hyoscine butyl bromide. That also can be given 6th hourly or 8th hourly, 20 milligram. But what I would like to suggest to you is that if your patient is coming to you with a high pain score, you will have to sometimes step on to that step 3 of the ladder. And you will just have to manage the constipation with your other drugs.
Usually we come across this sort of patients during house visit. And also
yes.
there are conditions like, they may not be able to go to hospital also. So how will be able to manage? When buying a medicine also difficult for them.
Yeah.
So which are the drugs you can?
Yeah. So at a house visit, generally what we do is that if it's a complete obstruction, like you had suggested earlier about, the digital evacuation and the enema, we do that. And we give then and there a dose of dexamethasone and an antiemetic. Generally, if there is no pain and all that, we might try a Perenome, but otherwise we give, if the patient is having severe vomiting, we give a butyl bromide, maybe give a Buscopan, and we visit the patient continuously for the next 4 days, 5 days, so that we can give a once daily dose. Or sometimes it is also that, in some home settings, we put a sub-Q needle in place, and we give pre-filled syringe, and we educate the caretaker how to give the drug. It's like a medicine box that we give them. So
sorry, this dexamethasone we give IV, is it 16 to 24 milligram, or how is it? Is it given IV?
We give IV, but do not push. We have to give it diluted, because at this dose of 16 milligram or 24 milligram, if you're going to push it, it's very distressful for the patient. The patient feels some sort of crawling kind of feeling, especially in the anal area. It is very distressing for the patient. So we usually give always diluted in 100 ml NS. Right? So that's about the pharmacological. Then surgical, there is resection, there is colectomy, ileostomy, colostomy, and I'm sure you all have seen that ileostomies are the worst than colostomy, because there is always a large volume of secretions in ileostomies, and there is more of excoriation that is seen for patients who have ileostomies than colostomy. So that also has to be thought about when you see your patients who have an ileostomy. Now, invasive procedures, NG tube insertion, select your patients. You need not always tell your palliative patients to be on nil oral. Sometimes you can give them the benefit of sips of fluid or liquids in the volume that they tolerate. Okay. And I have had so many patients in their end of life having intractable vomiting, and they are put on Ryle's tube at home, and so that the patient caregiver can manage it better. So because otherwise it's very distressing, you're not able to control it with just drugs. So these patients, they tell that, I want to eat something, I want to drink something, I'm feeling so dry, I'm feeling, getting that quench that thirst. So what we tell them is that just give what they want. because anyways, it's just going to go out through the Ryle's tube. So that way the patient feels happy that they get the taste of the food, and but anyways, it's not going to actually trouble them because it's going to go out through the Ryle's tube into the bag. So that is another thing. And then again, we have other procedures like gastrostomy and colonic stent. So you really need to think twice, thrice before you advise your patients, your palliative patients, for gastrostomy or colonic stent, because you need to think about the prognosis of the patient. How many more weeks does your patient have? And then think whether it is justifiable to put your patient through that procedure. So yes, metoclopramide, you can start with 10 milligram 8 hourly, gradually increase it day by day to higher doses, or you can even start a subcutaneous infusion if there is severe intractable vomiting. And 5-HT3 antagonists and prokinetics only in partial obstruction. And haloperidol again is another drug that we could give for nausea and vomiting, 2.5 to 5 milligram over 24 hours. Or like I said, we start off with 1.5 and then you can increase it if needed. Anticholinergics, hyoscine butyl bromide 120 milligram per day subcutaneously can be given. Hydrobromide can also be given, but generally we give a buscopan. And again, we also say that do not combine buscopan and metoclopramide because they antagonize each other. Corticosteroids, dexamethasone 16 milligram per day IV, and it is better to be given before 3 p.m. And you can give it for a trial of 3 days or 4 days. And if vomiting subsides, you continue it with oral steroids. Steroids act by reducing the peritumoral edema. Somatostatin analogs, yes, octreotide 300 micrograms per day. You can give it in divided doses, 100 microgram 8 hourly. It will help to reduce the secretion, slow down the motility, reducing the splanchnic flow, increases the absorption of water and electrolytes, and it is also a potent anti-vasoactive intestinal peptide effect. And it is also given as a preventive step. Depot preparations are also available, and it is given along with steroids in carcinomatosis. So in a nutshell, this is what your prescription should look like. You have to have a corticosteroid there. You have to have an antiemetic there. You could add an anti-secretory agent there if it is a high volume vomitus especially, or you can add hyoscine butyl bromide if there is a colicky abdominal pain as well. And again, haloperidol is your other option of antiemetic that you could prescribe. This is a pictorial representation of stenting. Yes, we have a stent. We have this figure shown there, figure A, B, C, and D, where you can see that how the stent finally expands and then finally the lumen is patent. So you need to discuss it with your multidisciplinary team, attending the patients, whether your patient really requires a stenting. You need to think about the prognosis of the patient. How many weeks does he have? Now comes the favorite questions of the caregivers, and you are definitely going to be bombarded with these questions when, especially, when you have a home visit or even in the clinical setting in a hospital. Your patient is vomiting away, not eating anything, and the patient relatives are very petrified. They come and tell you that, oh my God, my mother has not eaten anything, not drank anything, everything, and more than that, she is vomiting. Don't we have to put IV fluids? Don't we have to start a parenteral nutrition? So what would be your advice? Who do we hydrate? When do we hydrate? When do we give a total parenteral nutrition? Yes? Any thoughts on that? Do you suggest?
As you said, we can put him on trials tube and feed him whatever he wants and let it come out.
Yeah, that would be something that we would practice in end of life. Yeah. And how about hydration? Do we hydrate? These patients will not be able to take anything. So do we put IV fluids round the clock at their home setting?
We can do it, and we can,
we could give it a try. We could give it a try, but we should also have in mind the risk behind it. Because when we are going to push in intravenous fluids into this patient who is not mobile, this is going to lead on to increased secretions. So in on one side, you are trying to control the vomiting. On the other side, you're controlling the hydration by giving a lot of fluids. What is going to happen is also that unknowingly, you're going to increase the secretions, and that could lead to more vomiting. So it is a very critical balance. You could give a pint of fluid or so, and then the rest of it could be managed with sips of fluid.
At least some maintenance dose we can.
Yeah, one maybe a pint or two, a maintenance fluid, or that you will have to, as you go on in practice, you will see that some of your patients, when their vomiting is still getting severe, sometimes you might also have to bring down on the IV fluids and probably promote more of oral sips and also anti-secretory agents. So that is a decision that you make as you are managing the patient. Now here I also get a suggestion that Dr. Bikram was asking, total parenteral nutrition is not an option in palliative care. Now I would like to also add in one thing that we have to remember is that all our palliative patients are not in end-of-life care. So we have patients who are right from the time of diagnosis. So your patient who requires a total parenteral nutrition, you just have to remember one point, that that patient should have a survival time at least of 3 weeks. And then you are justified for a total parenteral nutrition. You need not actually think about a total parenteral nutrition for a patient who is terminal and at home. It is not just the cost factor. Earlier, we had to have central lines, but now we can give total parenteral nutrition even in peripheral lines. But still, again, we have to check if it is justifiable for that patient. And here, Dr. Bikram was also saying that stents are very costly. Yes, that is also a factor that we have to think about when we are advising stents for patients, especially if there are multiple sites of obstruction. So your stent at one point alone is not probably going to suffice. Dr. Ravi was asking, can we add buprenorphine patch up front? Buprenorphine is going to take some time to act. I'm sure when you have used buprenorphine, the time of action for a buprenorphine patch to act on a buprenorphine naive patient is probably going to take you a day and a half sometimes. So it's not actually going to help you to relieve the pain in that patient right away. And again, buprenorphine has an issue of vomiting, nausea and vomiting for the first 3 days. So that is just one thing I wanted to add about that. Now, again, palliative care setting in ICU setup is the new take. And this case, how would you justify? Well, palliative care setting in the ICU, I don't know how much I would agree to that, because ICU is a setup where the patient is away from his family, totally isolated. ICU is a place where there is a lot of critical care management being given, a lot of aggressive treatment being offered. So whether our patients need to actually have so much of aggressive management, tubes going down, and also being away from the relatives when there is less time. But okay if the relatives are not equipped enough mentally, physically to take care of the patient, especially at this time when, the medical administration, medical management has to be a little more done aggressively, so that you can manage the symptom well. Maybe a hospital setting, palliative care management at the hospital setting can be done. I'm not so for palliative care in an ICU. That's all. Okay, right. Now, let's move on to the story of Sarah. Yes. So Sarah is a widower. She was staying with her children and who are living in the UK. So I'm sorry, she's not staying with her children. She's supported by her children who are staying in the UK. So pretty much she is here alone. And she is 62 years old. We just saw what was her clinical condition. She was in stage 4 of CA stomach with metastasis to the anterior abdominal wall. She discovered that she's having a progressive disease during her second cycle of chemotherapy. Okay. So what happened is that she developed vomiting and abdominal pain for 2 days, but was still able to pass small amount of stool daily. Now, what would that be?
It's not a complete obstruction.
There is a small amount of stool having vomiting. Sorry?
It's not a complete obstruction.
So
it's a partial obstruction.
It's not a complete obstruction. Yes, it is a partial obstruction. Now, that first obstruction that we are looking at, chemotherapy itself can cause constipation. So probably she had a prolonged constipation, which is a non-malignant one, and she was passing very little small amount of stool, and she is also having vomiting and abdominal colic as part of the increased abdominal pressure. Now, Sarah develops vomiting 3 to 4 episodes. Sarah develops vomiting 3 to 4 episodes per day, which was unrelated to meals. Vomiting was bilious with partially digested food. And on her examination, she was not dehydrated. Her abdomen was distended. Bowel sounds were sluggish. Palpable nodules on the abdominal wall, which were mildly tender. So what are we looking at here? It was a bilious vomitus with partially digested food. And she was not that dehydrated, they say, but vomiting was there. About 3 to 4 episodes per day was there. Bowel sounds were sluggish. What are we looking at? Well, how would you be able to tell which site it is now from the history?
Maybe liver metastasis.
No, I was saying like which site would
Small
be the
bowel
obstruction?
Small
bowel obstruction. Yes. So now with the history itself, without an imaging, we are pretty much able to make out, okay, this is small bowel obstruction that we are looking at. Now, let me just get to the next slide. Yeah. So in view of the persistent vomiting, a nasogastric tube was inserted. And Sarah was told that the nasogastric tube would be only a temporary measure for decompression, which probably tells us that Sarah was not too happy about the Riles tube, isn't it? That she had to be convinced that it is just done for a little time. Now, a CT scan was taken and it was confirmed that it was a small bowel obstruction with a transition point at the proximal jejunum. Now, as she was still opening her bowels, the impression was a partial rather than a complete bowel obstruction, which already you all have agreed to. Right. Now, the intention of management is to reverse the obstruction. Now, you do know that there was still bowel sounds being heard. There was still small amount of motion being motion. So it is not a complete obstruction. So what would be your line of management for this patient? Yes. What would be good for her? There's still some element of reversibility in this. So what would you like to give her? We just discussed about the medical management. You could say, you could put it on the chat box. Yes. Dexamethasone, metoclopramide. Okay. Yes, that's right. It's just a partial obstruction. We could give a prokinetic like metoclopramide. We have to give a corticosteroid like dexamethasone. What else can be helpful for her? Right. Opioids. Let us see. Sorry.
Opioids, morphine, fentanyl.
Well, she did say that she is having pain.
Here it reads she was started on fentanyl infusion for worsening of nociceptive.
Well, no, I mean, in this particular context that she was having vomiting about 3 to 4 episodes per day later on, and the vomitus was bilious. I might wait before I start morphine because she didn't actually complain of pain as such over here. So I'm just going to wait a bit. So if there is a severe pain, definitely I would think about it. So here what was done was that she was given a suppository, a bisacodyl suppository, and a regular interval intravenous metoclopramide, 10 milligram for 8 hours duration, and intravenous dexamethasone, 8 milligram per day. So here she was also started on fentanyl infusion, 10 microgram per hour for worsening of, so this is what you were saying about, for worsening of nociceptive lower abdominal pain for the peritoneal metastasis that had been present for the 2 months. So probably by then she started having pain and she was also started on fentanyl infusion. So here, what do you think about the treatment that she was given? She was given a suppository, she was given metoclopramide IV, and she was given dexamethasone. Would you modify that prescription if you were in that place? Any suggestions? You have a suppository here, you have IV metoclopramide, you have IV dexamethasone. Would a suppository be your choice?
Suppository may not be that useful in small bowel obstruction.
Yeah. You could first and foremost, we always say, do a digital examination, check for impacted stools, and accordingly you can manage. But most often what we do is that we give enema, and if the patient is having vomiting, there is no point actually giving oral laxative at this point. So this is how generally we manage. And again, now with this, the patient has started on a opioid like fentanyl over here to manage the pain. But what happens instead is that he is also started, Sarah is also started on IV metoclopramide, which was increased to 60 milligram per day on the following day. Now, she has some improvement for 2 days, and the NG aspirate also came down, and she didn't have vomiting, and they were able to remove the tube.
Ma'am, the slides are not moving.
Oh, I'm so sorry. I will do that. Yeah. So what happened is that later she did not develop any bowel action. So that could be probably because of the fentanyl that had kind of worsened her constipation. We need to keep that in mind. Then again, now metoclopramide was increased by the physician to about 60 milligram per day. And later on with that prokinesis, she markedly improved. And the NG aspirate also kind of came down. She didn't have vomiting anymore, and they could take off the nasogastric tube, just like how they promised Sarah. And IV metoclopramide and dexamethasone were continued after 2 days. For 2 days, and then stopped subsequently. 3 days later, she started vomiting again. So, and she developed 3 episodes. 3 days later, she started vomiting again, and she had 3 episodes of vomiting in a day, which was moderate to large amount of bilious vomitus. And again, she was recommended IV metoclopramide 60 milligram per day, dexamethasone 8 milligram per day, and IV ranitidine 150 milligram BD to reduce the gut secretions. Now, what do you suggest? Where was it that the problem was so suddenly in 3 days' time? Again, she developed vomiting. Would you like to alter that prescription a bit? What happened over here? Her metoclopramide was hiked to 60 milligram. That is when her vomiting, she developed bowel movement, and her vomiting also came down, and they could pull off the nasogastric tube. And then what did they do? 2 days more, they gave metoclopramide and dexamethasone, and they stopped it. So what does that tell you? Any suggestions?
Rebound vomiting should have been continued.
Yeah, it should have been continued, right? They could have probably the dose of the dexamethasone could have been tapered, and it could have been continued. And metoclopramide also, they could have again tapered the dose. Probably TID could have been tapered to BD dose, and then probably they could have watched for how things are going on. She should have been put on regular laxatives, right? So all these could have been done. But what has happened? It was stopped abruptly, for which she developed a recurrence. Now again, look at her dose of dexamethasone. She was given only 8 milligram, which is probably not enough to bring down sufficiently the peritumoral edema. Now, despite the above treatment, Sarah's symptoms persisted. So here, now the goal of care was established after discussing with the patient and her family that it is just conservative management that can be done further. And she preferred to keep the nasogastric tube for decompression, while she enjoyed taking fluid orally. Now, when she was convinced that she could take oral fluids still, even though she had the obstruction, she had the complaints of vomiting, if she had the nasogastric tube there, she could still take fluids. She preferred keeping the nasogastric tube. And decision was made after discussing the goals of care with the family that they would stop any further chemotherapy and proceed for comfort care alone. So when do you think actually the goal of care should have been discussed? Was it like after all these multiple episodes that she had? When do you think that the family conference should have happened? At the time when the post-chemo progress, exactly. So do most of you agree as to what Dr. Ravi was also telling over here? Right when she progressed on that second cycle, they should have discussed about the goals of care. And Dr. Airaba Zahur says that before the symptoms, before it got worse, and maybe even when she was diagnosed with a stage 4 cancer, that is when they should have called for a family conference and discussed about what is the possible prognosis of this patient, what will we be anticipating as issues in this patient, and how we will be managing at that point of time. So what happened was she went home with the Rides tube, and she was basically, it was a care continuum at home, right? So this was the story of Sarah. And I would also like to put in a word about bowel irrigations, because we had discussed that colostomy is so distressing for patients, and these patients just do not mingle with the crowd, or they just refuse to go out of the house. And many of the times, I've had patients who were professionals, some like 2 of them who were doctors, in fact, who got treated, completely cured from their CA colon, and they just refused to get back to work because they had a colostomy. And one of the doctors was an orthopedic surgeon, and he was like, how can I stand for surgeries with a colostomy? So that is when we educated him about bowel irrigation, how it can be done. And I was so happy to see the next follow-up that he had started going back to work. So bowel irrigation can be practiced for 21 days at a particular time in the morning, say time it like 7 a.m. in the morning. And once it is practiced for about 21 days at a stretch, the bowels get into a habit of evacuating at that particular time alone, and then there is no soiling thereafter. And these are the different components that are used for bowel irrigation. You have an irrigation bag, there is a tube, there is a cone in the tip which is inserted into the colostomy, and there you can see the ostomy belt and the clip with which you can seal off. You will see it in the next picture. And this is an irrigation sleeve through which actually the fecal matter is washed out, right? So this is how it is. The patient sits next to the commode and probably and hangs the irrigation bag with lukewarm water. And this is hung in probably in the towel rod in the washroom. And the water is let to drain into the ostomy through that conical shape. And once the fluid is entered into the through the ostomy, it is clamped, and after a while it is let open, and through the sleeve the bowel is irrigated and all the stool is flushed out. And this is how it is usually done. So yes, we come to the end of this session. So by now we know what is the different classification of intestinal obstruction, what are the symptoms that your patients will be presenting to you with, which helps you to diagnose whether the patient is having a bowel obstruction, and where the bowel is obstructed. You can understand even that, and how to manage and how to treat a bowel obstruction in a patient who is receiving palliative care, right? So any more questions? Yes, so I think we have now 15 minutes time for the case presentation. We got to run to that. So if you have any questions, please let me know after the presentation. Okay, so I will stop sharing right now. Yes. Yesterday, Dr. Satyajit is presenting, right? Yes.
Good evening. Am I audible?
Yes, you are. Please
Thank you,
go ahead.
Yeah. So moving in line with the discussion today, I'll be presenting a case of bowel obstruction. Next slide, please. So this was a 62-year-old postmenopausal female, and the diagnosis was she had malignant ovarian cancer with bowel obstruction when we received the call. Next slide, please. So the presenting complaints were abdominal distension for 30 days. There was pain abdomen for 18 to 20 days, and she had no passage of flatus or stool for the last 7 to 8 days. And this was associated with vomiting since the last 2 to 3 days. Next slide, please. So coming to the history of present illness, she was diagnosed with advanced stage ovarian cancer, stage 3, for the last 2 months. And then imaging guided biopsy showed high-grade serous epithelial ovarian carcinoma. She was treated with neoadjuvant chemotherapy in the form of carboplatin and paclitaxels. 3 cycles were planned, but she received 2 cycles when she developed the bowel obstruction, and the patient was referred to the palliative care clinic for palliative management by the oncosurgery team. Slide, please. On examination, the patient was cachectic with a distended abdomen. There was an NG tube and an IV line in situ. She was mildly tachycardic. Her pulse rate was around 100 per minute, regular. Blood pressure was around 100 by 60 millimeters of mercury. She was afebrile. Coming to the pain, if we look at the provocative and the palliative factors, it was more or less continuous in nature. The quality was colicky. It was diffuse pain. She could not localize the site of the pain, but she did say it was radiating to the legs. And the severity was moderate to severe pain. The VAS score was around 6 to 7. And the patient was having a grimace on the face and she was not able to lie still. Next slide, please. The investigations were not very remarkable except for anemia. Hemoglobin was around 8.5 grams percentage and a serum albumin of 2.1 gram percentage. Next slide, please. So the treatment that she was receiving at the time when she was referred to us was she was getting IV tramadol 50 milligrams twice daily. She was on paracetamol 500 milligrams 6th hourly, and she was getting metoclopramide 10 milligram twice daily. And she was also getting octreotide 100 microgram thrice daily subcutaneously. Next slide, please. Coming to the psychosocial aspect, she had 2 children, both were married but were settled elsewhere. But the younger daughter had presently returned along with her own children to be with her mother. Her husband is a pensioner, but he had not gone for collecting his pensions for the last 2 months due to his wife's ill health, and the finances were not in a very great shape. Next slide, please. So the main concerns for the family was the failure of treatment despite neoadjuvant chemotherapy and the progression of disease to stage 4. There was liver involvement and extensive peritoneal caking. This was associated with a bowel obstruction. There was pain abdomen, and added to that, there were financial problems that the family were having. Next slide, please. So to summarize, a 62-year-old postmenopausal female presented with the progression of malignant ovarian cancer with bowel obstruction and pain abdomen. Next slide, please. So the discussion points today are how else would we manage the pain, the management of the bowel obstruction in this case, counseling for home palliative care because of the poor condition of the patient, the surgeons did not want to go in for any more invasive treatment. The concerns of improving her quality of life and preparation of her family for the final journey. Thank you.
Thank you, Dr. Satyajit. That was a very nice case. So the discussion points are open. So one question before we move on to discussion is, I would just like to know, was this the prescription, the pain prescription that was given after the patient presented with this core pain, or was it that on this prescription, he was having a pain score of 7?
Yeah, so despite the tramadol treatment of 50 milligrams thrice daily, she was reporting a pain score of 6 to 7. And she was also getting paracetamol in addition to the tramadol.
All right. Okay. Right. Yes. So how would we like to modify the pain prescription? Can you get to the details of the clinical pain?
Yeah, the pain was colicky in nature. It was not localized. She could not localize it. It was diffuse. She just, when asked about where the pain was, she just pointed to her abdomen. And there was no provocative or palliative factors. It was not relieved. It was more or less continuous. There was nothing that was bringing on the pain. It was spontaneous in onset. And the duration was, like I said, the pain was there for past few days. But the patient said that she had the continuous pain despite the treatment. Yeah. So the palliative provocative factors, it was continuous in nature. The quality, it was severe. VAS score was around 6 to 7. PQRR radiation, it was radiating to the legs.
Right. So definitely we are looking at a very high score of pain, right? The patient has got 2 analgesics here. Yeah. 2 analgesics over here, and again the pain is high. Now I would like to know one more thing. The patient has also been put on metoclopramide 10 milligram twice daily.
That's right.
And you also said that the patient is having a colicky type of pain.
That's right, ma'am.
Yeah. So I was just wondering, is it that the pain has got worse after the metoclopramide?
We didn't ask her at that particular point of time, but now that you, after the discussion in this today's topic, probably it could have worsened.
Right? So I was just wondering, is that the culprit here? You know, so maybe before we jump to morphine, I would also think that. Should I be actually cancelling off that metoclopramide, which could be looking at which could be the trigger factor here. And the patient also says that it is colicky in nature. So I'm just thinking maybe we could add in an anticholinergic. Would you all agree to that? Maybe a buscopan would help? Yes, I have a lot of answers coming here. Like most of her pain is due to obstruction, yes. And paracetamol could be continued to 650 milligram TID or 500 milligram QID, or would add adjuvant like Drotin help. Okay, then dexamethasone 16 milligram PPI. Yes, we did not see dexamethasone at all over here, isn't it? So definitely dexamethasone has to be added in. She's got colicky pain, and buscopan could be very useful for her again. And definitely enema. We did not see the prescription having any laxative. So definitely we cannot miss out on that aspect. Patient has to be given a laxative also. So I think with that, and probably if the pain is not coming down, definitely it's a high score pain, we could start the patient on morphine, step 3 analgesics. And a paracetamol 500 milligram 6th hourly was given here. You could, sorry, yes?
No, ma'am. Yeah, just it was 6th hourly, not yeah.
Yeah, 6th hourly. We could hike it even till about 1 gram 6th hourly. That's the max we can go if her biochemical parameters are fine. So with all that, I think that should be able. That way, we should be able to manage her pain. Now coming on to.
I just had a doubt regarding the analgesics. Like she is reporting severe pain. How long do we wait when we add these things like dexamethasone and
immediately? Okay,
so we give morphine in spite of adding these things.
Yeah. Once we diagnose that it is a bowel obstruction, we definitely malignant bowel obstruction. Immediately we start our combination therapy. Yeah. Okay. Then a management of bowel obstruction. So here for management of bowel obstruction, we have our dexamethasone, we have our laxative, and we have our anti-secretory hyoscine butyl bromide, right? So any other suggestions from the team? Yes, a lot of you have suggested buscopan and digital evacuation enema. Yes, Dr. Praveen was asking a general question regarding the eligibility of a specific condition under palliative care. Could you be a little more specific on that? Like, I was not able to get what you meant.
No, madam, I was just asking a permission to ask a question.
Yeah. Please do.
If the case discussion is over.
Oh, okay. We will be done in another 5 minutes. Yeah,
madam. Then I will ask them. Thank you.
Okay. So regarding counseling for home palliative care for her. So we had already discussed like we could give IV at home once a dose daily. You could pay a visit to the home and give her shots, or you could preload the syringes and keep a subcutaneous needle intact and tell the patient relative how it can be administered. And that is how you could probably set up a home conservative measure for her. And any other suggestions on home palliative care from everybody?
We need a palliative team.
Yeah, we need a palliative team coming and visiting her. Yes, because these patients are progressing in their illness. So what we present with today may not be what they are having in a day or two, because they could be developing new issues. So we need a team on call also, like they should be given phone numbers, contact numbers, who to call. Now, improving her quality of life. I guess if we can manage her physical symptoms, now her psychological symptoms could be managed by having a family conference and by educating the family on what are the possible issues, physical issues that she is going to be having and how it can be tackled, and the psychological support, which is very vital for her at these last days. So that also can be helpful to get more support from her family, and which is also probably going to bring down her psychological distress. And again, at other financial aspects also, which is affecting her quality of life, maybe connecting her to societies for funding economic support. The family is having other economic crisis where food kits or even these drugs can be supported. Preparation of the family for her final journey. Definitely, it is about educating the family, telling the family that the palliative care team is readily available. Assure them your support, and any queries at any time can be even resolved telephonically. Or if a 24/7 team is available on call, give them numbers on that. And again, palliative care is not about just attending the patient, but also family. Even after the death of the patient, palliative care extends as bereavement care. Yes, so now coming on to the questions in the chat box regarding this case, what about patients with hypertension? Do we give them Dexa 16 milligram or is there an alternative? In palliative care patients, we generally do not decide our medications. This is in end-of-life care, okay? We do not decide our medications looking at the comorbidities. We just think that we will go ahead with what is most required for the current medical distress that the patient is having. And if the BP is shooting up, then we will just look at it at that time by adjusting the dose of the antihypertensives. So it is not that we do not give a patient dexamethasone just because the patient is a hypertensive. And regarding the other question, escalating to hospice care, caregivers also be addressed. Okay, so you were saying that we could also suggest about hospice care. Yeah, hospice care can also be given, but generally, in an Indian setup, generally there is it is not just a nuclear family. So there are many people at home who are readily available to take care of the patient.
Is it only for me? Sorry to
Yeah.
I think your
Do we have
voice
any
was
more?
breaking.
Do we have any more? Yeah, now is it audible now?
Yeah, perfect. Yeah.
Yeah, okay. Yeah, do we like to any more points that we better for with ovarian cancer? Yes, Dr. Mishra, is it fine? I mean, have we discussed all the points?
Yeah, ma'am. Thank you so much. I think all the points are covered.
Okay. All right. Yes, now moving on to the general question that Dr. Praveen wanted to say. In terms of decision making regarding a surgical correction like removal of a part of a bowel, etc., is taken by whom? Which specialist in palliative care team? In terms of a terminally ill patient, if it could temporarily alleviate the condition. Now, palliative care, when you talk about palliative care team, it is always a multidisciplinary team. It is not just a palliative care physician and the palliative care nurse. There are multiple people in the team. So you will have the treating primary physicians, you will have the palliative physician, you will have the palliative care nurse, you will have the psychologist, you will have the medical social worker, you have the pastoral, you have the physiotherapist, occupational therapist, you have the dietitian, you have the volunteers. I mean, it is a huge team. So definitely active management like surgical management here will be taken by the surgical oncologist, because you will be having to discuss it with the multidisciplinary team here.
No, madam, if you don't have that much facility, we can directly send it to medical college nearby.
Yeah, you could. So what you could do is that when you see a patient with malignant bowel obstruction, just think of that flow chart which we saw in the slide. And accordingly, you will be able to know, is your patient a candidate for surgical management? And accordingly, you can make the referral.
I think for Indian scenario, that would be better. Because,
Right. Correct. And in terms of terminally ill patients, you really have to think whether you want to put your patient through the whole thing of anesthesia and the surgery and all that, because you need to. It is about counting the number of days available and seeing if is it the distress of the obstruction that is going to be more painful for him, or the distress of going through the surgery and its after effects are going to mount the symptoms.
Thank you, madam.
Yeah, and please elicit the non-pharmacological ways in this case. Yes, I think yesterday also we had this question, right? Non-pharmacological ways for a bowel obstruction, I would not say there is for bowel obstruction per se, but the symptoms. Like say, we did look at the non-pharmacological management of nausea and vomiting. We did look at the non-pharmacological management of constipation yesterday. So I think it would be a blend of that. But again, for a malignant bowel obstruction, just because the patient is having a quiet environment and all that, it is not going to actually make a big difference that he starts vomiting, he stops vomiting. It's probably going to bring it less, but maybe not stop vomiting. So it might have some effects non-pharmacological, but it's mainly pharmacological. Yes, I think we have crossed the time again, 8 minutes past 6:30. But I hope that everybody has got their doubts cleared. And if you still have doubts, I'm always approachable. You can get my number and always send in your doubts on WhatsApp or mail me. You can get it through Sripriya. Yeah. So thank you all very much. This was a wonderful, wonderful, wonderful session. I really enjoyed the interaction and I really enjoyed this group a lot. I have been taking a lot of classes, and your group definitely I enjoyed very, very much. Thank you, Pallium India, for inviting me and allowing me to be also part of this group, teaching and learning from them. Thank you very much.
Thank you so much, Dr. Vineetha. It has always been our pleasure to have you with us. Your pleasant interactions and the mutual learning sessions has always been an eye-opener for everyone present out there. I hope everyone will agree. And please don't forget to leave your feedbacks regarding the same. I have already shared the link in the chat box and we'll be sharing the same in the WhatsApp group as well. And so with that positive note, this is Sripriya along with Dr. Vineetha Rijju signing off from the Tips Echo Hub. See you in the next session with another interesting topic and another eminent faculty. Till then, everyone, stay safe. Bye-bye.
Bye.